everybody to this 11th annual Lee Hazenbush Visiting Professorship and Lecture Series. It's amazing that this is number 11. This is always a great day for the Mass Mental Health Center. It brings us all together, and it brings us together to remember and honor one of our former great faculty members, Lee Hazenbush. And I'll say a word about Lee in just a minute. And I'd like to introduce Grace Hazenbush, Lee's widow, who has sponsored and fostered this series, and with her spirit kept us going at flagging times, and it's really great to have Grace with us again. Grace, in her own right, was a member of our profession and worked very hard for many years, and along with Lee, were inveterate travelers, art collectors, but primarily supporters of mental health care, particularly for people who would ordinarily not get mental health care, or for the kind of people that most of us would rather say no to because it's just inconvenient in some way. And I think one of the things that characterized Lee and characterizes this institution is we don't say no to people. We say, yes, come on in, and we take care of them. And Lee would take care of them here and in his home in Brookline, and he never said no. I've made introductory comments about Lee for each of these, and I guess I probably will repeat myself, but let me reflect my memory of Lee, which is very, very clear. I'm sure Les could expand on my comments for hours. Lee was a very canny clinician. He was extremely well trained. He had trained at Hopkins and then come here and was on our faculty, worked in the outpatient department, supervised residents. He supervised me. And Lee had a very acute eye for people, and he knew how to read them and how to talk to them, and he knew how to be helpful in a non-threatening way. He also knew how to be helpful to residents in a non-threatening way. Supervision with Lee was always a supportive and educational venture rather than a critical and punitive one in which you kind of slunk away feeling that you're in the wrong business. Lee, in his later years, he had a kind of a crusty demeanor. He'd kind of look and scrunch up his face like that, and he'd listen to the patient, and he'd listen to you, and then he'd ask some kind of very penetrating question, which always managed to elucidate the patient's problem. And then he would help design a treatment program. And one of the things that was wonderful about Lee is he was not wedded to any particular philosophy, nor was he shackled to any treatment program. He designed what was good for the patient. So even though he was well-versed in psychodynamic theory, he was also experienced in group therapy, and he also knew a lot about how the real world worked, so that he could help some of the sickest of our patients find their way through the morass of mental health services, outpatient facilities. And he could be quite direct and straightforward to talking to them about brushing their teeth, getting their hair combed, and behaving themselves, while at the same time talking about the losses, the pains, the anguish, and the fears. As Lee got older, he got cannier. And I guess as people get cannier, they get a little bit more quiet. They listen more rather than talk more. And listening took on an even more acute edge. And I remember talking to him quite a bit about some of my own patients. By that time, I was back here on the faculty, so we were colleagues at this time. And always heartened and helped by Lee's comments. He got sick, as inevitably will happen, and then passed from us, really leaving a legacy that I think everybody who was here during Lee's period remembers. And I think almost everybody remembers him exactly the same way, because I've talked to dozens and dozens of former residents, psychologists, social workers, faculty, people of all kinds. Everybody sort of has the same memory as a charming, funny, worldly, cultured, but devastatingly acute clinician who helped everybody. And so, to me, as I think I've said in past years, Lee embodied what the Mass Mental Health Center stood for and still stands for. And so in a way, we're not only celebrating Lee, we're celebrating us. And in that spirit, we'll feed people after our speaker. There will be a luncheon from 12 to 1:15. The lunch is available for those who indicated they were going to come for the lunch, because we don't have enough for those who didn't say they were going to come. But we will welcome everybody who said they were going to join us right next door for lunch. At 1:15, we'll regather here for a case conference, and then some concluding remarks by our speaker. Before I introduce our this year's speaker, Les Havens, I would like to introduce Ming Swang, who has some opening and welcoming comments about the Mass Mental Health Center. Ming?
Welcome everyone, and particularly Mrs. Hazenbush. Each year we have this Hazenbush lectureship, and I thank you so that I have an opportunity at least to say a few words about the Mass Mental and say about the current status of Mass Mental. For those PGY 1 or 2 who have never attended this occasion, I'd just like to briefly mention about the history of Mass Mental in a very, very short few sentences. This was established, opened the door in June 24th, 1912. And believe it or not, this was an effort by Dr. Vernon Briggs, who was a predecessor to now our Ken Duckworth is going to take over as a deputy commissioner for clinical and the professional services. He was a psychiatrist at the Department of Mental Health. At that time, it's called Mental Department of the Boston Dispensary. And he felt that all the patients that warehoused in a state hospital is not right, need acute evaluation and treatment. And the right place is next to Harvard Medical School. So he campaigned and appeared in the legislature and then persuaded them to buy this lot. So 9 years of struggling. You see, 9 years of struggling and fight and to achieve his cause. Now Ken Duckworth is going to take over that position, so you have a mission to have a new Mass Mental building.
Do I get at least 9 years?
9 years, 9 years. Then Mass Mental's name was changed in at that time it's called Boston Psychopathic Hospital. And in 1956, because of this community mental health movement, it was renamed as a Mass Mental Health Center. So this is the current institution name. And believe it or not, the first superintendent was a neuropathologist. And he was a professor, a Bullard professor at the Harvard Medical School. And because of his background, he did a marvelous, very pioneer work on the theory of the neurodevelopmental hypothesis of schizophrenia, which we are talking about. He took over in 1912, and he examined many, many hundreds of brain, and saw that in the prefrontal, the cell seems to be hypoplastic. It is not the degeneration, it's a hypoplastic. So he said this must be a maldevelopment of the brain. So now we are talking about our neurodevelopmental theory of schizophrenia. And his publication on this area is the enlarged ventricles, and published in 1915 in the Journal of Nervous and Mental Disorders. In 1915, he already focused. The brain is the site of the schizophrenia. And however, he is a very good clinician. By reviewing his case notes, by reviewing the information which I got from the history of this place, this institution, he sees patients. He sized up the patient's mental condition very quickly after 20 minutes of interview. And he is another hallmark. We are now talking about the parity. He is really the first one talking about the parity. He actually see at that time it's called Brigham, what is the hospital there called? Peter Ben Brigham. They treat the medical patients so well, but no one pay attention to treatment of the mental patients. So he emphasized parity. Now we are talking about parity. The first superintendent already mentioned the parity. And he also said social environment is very important, and the treatment should be involving a social concern. So after that, through this Dr. Solomon and Jack Ewald and Elvin Sermert, how to pronounce this? Samrat. I have to be able to pronounce this to be qualified to work here. And then Milton Greenblatt, Miles Shaw, and all of you here, the distinguished senior professors, and including Les Haven. He is the distinguished lecturer today. All these distinguished psychiatrists are very, very competent clinicians. Then the teaching, then the research. These three should be joined the forces. Without research, there is no new insight, new information. And with the new information, we can teach and apply to patient care. So this is the mass mental. Now move to this era. We, mass mental, now have three emphasis, missions. With the this center's director, Jackie and I, we decided the first mission is to take care of homeless people. This is very important issues. Second is to eradicate the stigma. So these are very important things for psychiatry. And now with the research, we are moving into primary prevention. The reason primary prevention is that the treatment and intervention at the first episodes, these could be done. To modify the symptoms, we could do it pretty well with the new technique of neuroimaging, neurochemistry, neurophysiology, neuroanatomy, genetics. We now will be able to identify subclinical syndrome, or even before the development of the condition. So we are pursuing the concept of schizotaxia, predisposition to schizophrenia, and to be able to prevent the occurrence of schizophrenic spectrum disorders and psychosis. So this is a new era for Mass Mental Health Center to pay attention to primary prevention. You are going to read several papers of ours published in American Journal of Psychiatry to essentially change the concept of what is schizophrenia. And the schizotaxia, the predisposition to schizophrenia, is one of the very important aspects of this institution's future research. And we are currently doing a lot of work on this. Sorry, I take some of your time, but this is just Eugene gracious opportunity for me to be able to talk about the mass mental. And we now established Massachusetts Mental Health Institute of Psychiatry in conjunction with research cooperation and to really pursue those missions. Thank you very much.
Okay, this is a moment I have been looking forward to for a long time, the moment when I can introduce Les Havens to people in this audience who don't know Les, and for those of us who have known Les, just refresh our memories and experience. Our lecturer today is Dr. Les Havens, who was a seminal figure here at the Mass Mental Health Center and is really a seminal figure in world psychiatry even right now. And I can't think of anybody who really should be a Hazenbush lecturer more than Les Havens, because not only did Les and Lee work together and embody some of the spirit and tradition of the institution, but Les, like Lee, also gave so much to this institution in spirit as well as in knowledge. As I understand Les's career, there were three basic periods. Les arrived here in 1954 and initially was an organically based psychiatrist. He ran the ECT unit. He was a psychopharmacologist. He wrote some of the early great papers on psychopharmacology, including papers that then led to some of Tom's great papers on the importance of therapeutic alliance and prescribing medications, and work that's really never been surpassed, in my opinion. When I arrived here in 1964, Les was in what I think might say the second phase, which was his interest in psychiatric history and to some extent philosophy. And he was trying to place psychoanalytic theory, which was dominant in this institution as everywhere, in a more world context and a historical context of other movements in psychiatry. And so residents here read Harry Stack Sullivan and read the Europeans and read other early Americans, as well as the dynamic formulations. And all of Les's teaching at that time was informed by what I think is characteristic of Les, a broad, inquiring question. What does this mean in the large context of what we know about humans? And it was from here that he launched into the third, and I think currently still very lively phase, which is the examination of what goes on between doctor and patient in not only an extension of the traditional dynamic kind of formulation, but a humanistic and compassionate understanding of what it's like to be a patient, what it's like to be a therapist, what goes on between the two, and what are the elements that might make for growth and even therapeutic change. And in this phase, Les has written some of his greatest books, books that really are must-reads for trainees and are must-reviews for those of us who practice and get a little bit distant from this wonderful thinking. The Mass Mental Health Center was the foundation for the Cambridge Hospital Department of Psychiatry. A whole group of people led by John Mack left here to found the Cambridge Hospital, and ever since then, there's been a steady movement of Mass Mental Health Center people from here to Cambridge. Les, after being one of our most beloved and sought-after teachers, followed in that tradition and moved to Cambridge, where for many years he was the director of the residency training program and continued some of his writings. He's now still there on a slightly more part-time basis, still practicing and still writing. And so it is a really great pleasure to welcome Les here. The last comment, Les, before you stand up, something you've heard me say, but I have to say it again. I have never attended a lecture of Les's in which I didn't learn something that was useful, important, or clinically relevant. Never. And I expect that will be true this morning. Les? There are still some seats up here.
Thank you, Carl. And thank you, Mrs. Hazenbush, for being here, for helping to make this possible, and for giving us your husband, and many times that he spent here away from you. He was a wonderful man. He was very central in this place in many ways that were quiet but effective, and I'm greatly honored to have any connection with his name whatsoever. Now I return here with a great deal of feeling and trepidation too. This institution was my second home for 26 years, and very important in my own history and concerns and conflicts and all the rest. So it's going to take me a little while to settle down into this, to get myself some kind of manageable form. My earliest work was in biological psychiatry. I'm proud to say that as a resident I had the lead article in the New England Journal of Medicine in which I had discovered a new psychosis. No one ever remembers that because years later I found out that everybody thought it was done by a man by the same name who was a professor of hepatology actually at Pennsylvania. So I lost the credit to that. And furthermore, the English came along 6 months later and produced 6 cases of the same thing without mentioning my effort. But it was enough. That was delirious enough just to have been in the New England Journal of Medicine as a young man. And I also won the first prize of the Society of Biological Psychiatry, and for work I did in ECT on catecholamines. And I'll come back to that at the very end because I want to tell a story which illuminates the difficulty of what I'm going to say today. In the meantime, as Carl says, I tried to work on how to talk to people, what the forms of language which make it possible to communicate are. And you're going to see that I'm going to be using two of those forms today. And this afternoon, I understood I was supposed to talk again at 3 o'clock. And what I'll do then is to give a history of the 20th century's development of psychiatric ways of talking, which each of the schools have specialized in. Not only ways of talking, but how the physician, the therapist, or the therapist and the patient place themselves vis-a-vis the patient. I'll come back to that. You know that one of the most famous events for which this institution for a long time was enveloped by was psychoanalysis, in which a placement between the patient and the therapist is peculiar, isn't it? The therapist goes out of sight and someone lies down. And I'll talk about the 4 principal ways we've been taught to place ourselves and talk this afternoon. But today I want to talk about the subject of where we are and where we should go. Where do we go from here is the title of this. Now, today, as Ming was adumbrating for you a little bit, today we are the the proud possessors of an enormous promise. That is the promise of understanding the human brain. This is the central fact of contemporary psychiatry. And it, for those of us, any of others who remember what the brain was like in 1954, when I entered the field, will see what an astonishing change this has been. The human brain that I was taught about in medical school was a sort of gray blob. It could receive, it could send, it somehow processed things. It didn't develop after a very young age. It couldn't repair itself. It was an organ astonishingly different than what it was doing in terms of mental phenomena. Today that has changed. Today we have watched the human brain over and over again be changed in our understanding of it in fundamental ways. It can repair itself. It's extraordinarily plastic. It has resources that probably will always resist us because of its complexity. Some of you know the famous Emerson Pugh's statement about the brain. If the brain were so simple that we could understand it, we would be too simple to understand it. That doesn't forbid us, though, from embarking on a productive course, which Ming has been one of the leaders in, to make this brain understandable to us, and with it, the difficulties that we encounter clinically. Now, the point of the words that follow is very simple. Knowing what the human brain is like and what it can do, even knowing some of the forms of its pathology, is not useful clinically until something else happens. The forms of the human brain do not become useful to us clinically until something else happens. And I want to suggest one of the ways that something else, one of the forms that something else could have. And I'm going to illustrate it first from the history of 19th century medicine, because 19th century medicine gave us an extraordinary experience of how a comparable set of discoveries could be put to use clinically. Now, the comparable set of discoveries were about human pathology, bodily pathology. The emergence in the 19th century of a real working, post-mortem discovered human pathology was the triumph of the 19th century. But they also had to face the problem of how do I use what I've discovered in death on the living human body. Now I want you to contemplate that for a little while, because it isn't self-evident what you do. Because you can't cut the person up to find out, although you can try get close to it surgically, but there's an awful lot of things you can't do that you have to work from the knowledge of. And how the 19th century discovered means to do that, I want to challenge you, because that's got to be your job. And my job, I hope, if I'm around long enough, to help in it. How do we go from the living human body so as to use what our textbooks of pathology tell us could be going on within that body? Now, at the time when the discoveries that I'm going to discuss with you, at the time they were made, 19th century medicine closely resembled the situation we're in today in psychiatry. Closely resembled it. Let me mention some of the features. In the 19th century, there was no such thing as general medicine for most of it. There were the schools of medicine. The homeopaths, the allopaths, the regular physicians. There were a group of them. And they felt about each other pretty much the way the contemporary schools of psychiatry feel about each other. They didn't like each other. They were threatened by each other. There was nothing like a medical school instruction, nothing like a medical school instruction in how this whole thing could be seen as a whole. That was unknown to education in 19th century medicine. Another feature was very clear. What dominated diagnosis in the 19th century was self-reports, syndromes, accounts from the patient of what was the matter with the patient. This was the almost exclusive source of information for clinical decisions in 19th century medicine. And I don't need to remind you that that remains the case today in psychiatry, that we are helplessly dependent on self-report. And there's a third feature that 19th century medicine shares with 20th century psychiatry. The emphasis in 19th century medicine was almost exclusively on pathology. And there are wonderful books, in fact, written about how a pathological system would degenerate in the 19th century and suddenly include everyone. It could be spread to everyone. And you watch this happening in the DSM, some of the DSM manifestations today. Because there was no way, and the reason for that, there was no way to limit disease on a self-report basis. So that what I'm going to be talking about really points right at that fact. How do we establish means by which healthy function is allowed to enter psychiatric calculations? Remember that in modern medicine, every disease is essentially an intrusion on a well-established healthy basis, whether it's the pulse or blood pressure or whatever. Everything is seen as a disturbance of a previously established state of health or close to health in the patient. Now that's what I want you to think about, how we could do that, and how we could do it routinely, because these triumphs I'm going to mention right now, these triumphs in 19th century medicine were quickly adapted, I shouldn't say quickly, they were adapted to be used at the bedside by anyone in a few minutes. When I was a medical student in New York, my professor of neurology used to play squash with me. And after we played squash, we would talk. And he told me the history of neurology. Not as he had understood it, but as his teachers had told him, their teachers had told them. So it was 3 generations back what he was telling me. And he said the greatest event in 19th century neurology was very simple. It was the introduction of reflex testing and pinprick testing. It was the introduction of routine, bedside, quickly done, reflex testing and pinprick testing for sensation. Now, what did that do? What did that do? It almost immediately allowed the observer to limit disease. It was here, not there. It was this part of the nervous system, it was not that. That could be done at the bedside in a few minutes. Something went on similar in cardiology with the introduction of percussion, as some of you also know. My professor of medicine was a great percussor, and he would love to put his great hands on the patient's chest and tap out the limits of heart size or the level of fluid accumulation, things of that kind. And not only was it a spiritual experience for the patient or for those watching it, it also allowed him to demarcate disease from health. It allows him, in a few minutes, to sound the limits of a disease process in the human body. Well, now you see what I'm trying to suggest to you, that these routine methods of clinical practice made it possible to begin to see, literally to see, where in the autopsy findings the lesions might be. Now, one of the extraordinary experiences I had in the 40s and 50s, and this was because my father was dying in New York, and he had a group of physicians taking care of him who were exceptional in their interest in medicine as well as their willingness to talk to me. And they told me what it was like to practice medicine in the 40s and 50s, and what it had been like before that, of course, but that was their experience. In those days, the really conscientious, devoted physician who wanted to learn, did his own autopsies. He did his own autopsies. And he did this for two reasons. One, of course, is to find out what had happened, but the other was to correct his clinical understanding. To use his percussion, for example, to see how that percussion, how to use it, to remember that percussion and see how accurately he could do it. So through his life, these people refined their clinical methods in relationship to their pathological understanding. Now, one of my embarrassments in making these remarks to you and these suggestions is that seems like such a long time ago. That seems like such a crude way to practice medicine. Do your own autopsies, to tap and hit patients with hammers and do little things like that. It seems so crude in our extraordinary technological era. It seems crude. But I think that's where psychiatry still is. And whether we can skip those steps to arrive at a real useful application of the extraordinary brain findings we are discovering and will continue to discover, I don't know. I certainly hope so. And this is really a plea for our being humble enough to realize that we may be at a very early stage of our development and need to use methods that will seem embarrassingly crude and old-fashioned. Now, the introduction of reflex testing and percussion and others, but those are the two most dramatic devices, made possible a series of things which perhaps you've already perceived. I mentioned one. It allowed them to limit disease. It allowed them to limit disease, and it allowed at the same time for them to say what was healthy about the person. This reflex is all right. That one isn't. Now, I emphasize that to you because nothing contributes more to the stigma that Ming was asking us to try to reduce. Nothing contributes more, in my opinion, to the stigma of our patients is the fact that we can never tell them anything good about themselves. I challenge you to look at your charts, and I've been looking at charts for 45 years, and show more than an occasional comment about health in a patient. We are a pathology-besotted profession. And this is, the patients know this, they fear it from us, and they wisely should. And I don't think that real progress is going to be made against stigma until we are able to say to patients what the internists and the surgeons say every day. You're looking great. Look at this x-ray. See that fact about what a healthy person you are. Now, you people don't go to doctors as much as I do, because I'm just about 76, and so I've seen a lot of doctors in the last 5 years. And I like it. I like it. I like it not only because they help me with a couple of fundamental problems, they cause some more, but they help me with some fundamental problems. But above all, I love to go to my internist because when he's through with his annual tapping out of my state, he looks at me and he says, well, your heart is great, or your lungs are fine, or you're this, or you're that, or your kidneys are working, and your potassium's normal. And I feel like most of me is all right. Most of me is all right. And that is a great relief. And in fact, he does it with such pleasure in finding that it communicates itself further to me. We don't do that. We don't do that. And we got to find ways to do that if we're going to overcome this stigma that Ming talks to us about. And those of you who grew up in the analytic era know that although Freud himself was extremely skeptical about what was health and what was disease, he had a mordant way about him. And so many of his followers, especially those that took him a little too literally, tended to see nothing but pathology in patients. And what Jung called, in his accusation against Freud, the constant unmasking of psychoanalysis was really not the unmasking of health and love and futures, but the unmasking of the psychological horrors that were supposedly repressed or buried within us. So one thing that these 19th century medicine did was to limit disease and to throw the concentration on health, throw the concentration on health. The second thing they did was to begin to dissolve the intense competition among the schools. Because once you had methods that could identify disease and then be confirmed at postmortem, many of the quarrels in medicine began to dissolve. Furthermore, you now had an educational process that you could set that everybody had to agree to. You had to learn about percussion, you had to learn about reflex, you had to learn about anatomy, you had to learn about pathological anatomy. So the work got going in the context of these discoveries. Now, as I mentioned to you, the physicians that I knew from the mid-century said their education continued. And the reason that the suggestions I'm going to make today, although there may be much better ones to do the same thing, the reason that those suggestions are important, I think, is that the understanding of disease was as much dependent upon the clinical methods in the living patient as it was in the pathological findings at death. They both trained each other. You learned how to do the tapping or the percussing better, and you learned, what had actually been going on in the body. And I'm going to close these remarks today in a short time, too, you'll be glad to know. Close these remarks with discussing how this process could go on in relationship not to autopsy, because that's not probably the way this is going to work. It will work in some respects, of course, as it has already, and as some of Elmer Southard's work suggested it could. But I think what's going to be the closer tool to clinical practice is going to be neuroimaging. And I want to talk about neuroimaging and the way we could use clinical methods in relation to neuroimaging in terms of identifying sickness, but also establishing what we mean by health. Now, how are we going to do this? What would be the psychological equivalence of percussion, for example, or reflex testing? How would we do that? And here we're confronted by a sad fact, I think, that most of the methods of talk that we use on an everyday clinical basis are interrogations. I like to say that after medical school, doctors have only two forms of speech left: questioning and ordering. And there's something to that. One of the parts of Freud's genius was he introduced another type of talk: silence, no talk. And that was a relief in many cases, because at least the doctors couldn't question or order; they had to listen. And that makes us indebted to him in a way that we must never forget. But what forms of speech would escape the terrible difficulty of questions? And here's a place that when I make these remarks to people, I notice the eyes glazing over, the minds turning off, and the hopelessness of my task stares back at me in a way that only a less fervent person than myself would resist. The problem with questions is twofold. First of all, you have to ask the question. The person has to understand it. They have to think about answering it. They have to decide whether you're the person they could tell it to, and then they have to put it into some kind of English speech. It's an enormous internuncial explosion, questioning. Furthermore, questions are inevitably coupled in all our experience with people we don't like being questioned by. Whether it's teachers or sometimes our parents, police officers, doctors, whatever. Questions invoke the desire of concealment, lying, fright, overtelling, exaggerating, all kinds of things that occur in this social experience of being questioned. Right? So what we want is some kind of method that short circuits all that internuncial business and goes directly to something and is not so likely to invoke the terrible transference baggage that question carries with it. We want something that produces more spontaneous results, more results less guarded, less subject to these distortions. We want something like percussion, that when we hit, we get a sound back, which tells us what's going on beneath that sound. And a good many years ago, I wrote a couple of books actually about speech which involved this, but I began to think more about what's called empathic speech. Empathic speech is something which is today greatly prized. It's a way of talking that reverberates with the experience of the other. When you say that or when you look awful, and I say to you, well, something must have gone wrong, or in other words, I make simple statements that might reflect the truth of your experience. That's empathic. We're sharing, as the contemporary cliche is, our experience. It took me a long time to realize that those remarks are always approximate. We never get it right. We never get to a person's soul, their feeling. It's always approximate.